and I hope it's been much more normal. But I'm gonna start. So it seems like we're gonna talk about deceleration. She is gonna, I do know from her, she's going to use the images that she provides in your slides. So it's good to know the pictures from your slides in terms of what's going on, because that's what she's going to use. So let's first talk about the fetal heart rate, right? The fetal heart rate is between 110 and 160 beats per minute. Bradycardia for a baby would be less than 110 beats per minute, persisting for at least 10 minutes. Keyword, at least 10 minutes. Tachycardia is a heart rate for a little baby like this, or the fetus, I should say, of greater than 160 beats per minute, persisting for at least 10 minutes, okay? So that's because an average fetal heart rate is rounded about 5 beats per minute for at least 2 minutes within a 10-minute window. In other words, you're looking at a range for the fetal heart rate. Like, you're not going to say, like how we would say for an adult, the heart rate is 80 beats per minute. You would say for a fetus, the heart rate is 125 to 130 beats per minute. So that's just what I want you to think about when we're talking about fetal heart rate. So we understand the normal, and now we can go into the different types of like variability, right? So variability could be is a very good thing. These are these irregular fluctuations in the fetal heart rate, which you might think, hey, this doesn't look so good, but it actually is, right? Because the variability, or these little waves, are letting us know that the baby's moving, that they have good oxygenation. So here's the problem, is that when we have variability and we're seeing all these different things, we need to figure out if it's normal or it's abnormal. Is there variability? Is there not? So wave motions, like in this first one, indicate some sort of variability, okay? But we need to determine the different types, because that's what she's going to ask you. So absent variability means that there's no squiggly lines in that fetal heart rate monitor, like this one. You see, it's just a straight line. These are actually late decelerations with absent variability. And I'm just telling you this because we're going to get into that in like 5 seconds, but I just want you to see this is an example of absent variability. There's no squiggly lines, there's nothing going on, it's just a straight line. A fetal's heart rate is never supposed to be a straight line, because their heart rate is like a range between, like, let's just say 125 to 130. You're not going to say, oh, their heart rate's 130. It's just not something we do. Minimal variability is the heart rate is not really fluctuating much. It's only fluctuating with less than 5 beats per minute. So maybe it's going between 130 and 132. That's not good either. You see the lines moving a little bit compared to absent. There's no movement, but it's not good enough. That's not good, okay? We could typically see this after someone who has a push of opioids, because remember, opioids slow things down. And absent variability is usually indicating fetal compromise, meaning this baby's not doing so good, okay? Moderate, which I don't think I have a picture here, but I think we're going to go by this one because there is a lot of variability. But moderate is 60 to 25 beats per minute, okay? So it's going to go greater than minimum of 6 and up to 25. So let's just say it's going in between 130 and 150, the heart rate. That's good, right? So like you could see with this line over here, right? Maybe the fetal heart rate's around like 110 and it's going up to 130. So that's pretty good. But marked variability is when they have a heart rate greater, a variability of greater than 25 beats per minute. So you see how that's the baseline, that straight dotted line, and it's really, really high. Like the markings are crazy, okay? So that means that fetal heart rate is going above 25 beats per minute, then it's normal. That's not really good either, okay? Now, decreased variability, like I said, not good, usually associated with opioids or fetal distress. So, accelerations, we already talked about that from the last one. Very good, right? That's just the movements that we're seeing. When we see accelerations or an increase in fetal heart rate, that is good. And we're looking for at least 15 beats per minute above the baseline, lasting at least 15 seconds. And that's at least 2 little boxes. So you could see, right, within, let's just say this, there's like a baseline and the heart rate's going up, okay? Usually it'll be a little higher than that, but that's the example I have in my slides. But it's related to fetal movement, and that's why we have the kick counts. That's why we emphasize them being so important, because they relate to each other. Having accelerations, feeling the baby moving, that means the baby's doing good. It's always reassuring. Decelerations can be good or bad, okay? So we have, I want you to know and memorize this mnemonic VEAL CHOP, okay? So VEAL and CHOP, and they relate to each other. So let's start with the V. The V stands for variable, okay? And the C in CHOP stands for cord compression, okay? So when this happens, you're usually going to see a U or V-shaped decelerations on that fetal heart rate. You're going to see like a U or like a V shape going downward, okay? And there's a rapid decrease in the heart rate. That's what that means. If you're seeing a U or a V shape in that deceleration, that is a rapid decrease in the heart rate. It could also be a rapid increase in the heart rate. Variable does not only mean it has to be decrease, which can be a little confusing, but it could be either. And it can occur with or without a contraction. So we know if we see variable decelerations, we're thinking about cord compression. When we have early decelerations, we think of H, right? That H in CHOP, which relates to head compression. That's a part of the labor process as the baby's moving down, trying to come out. That's normal, okay? And the fetal heart rate is going to decrease at the same time of the uterine contractions. That is going to be normal. And as an example, here's an early deceleration. The fetal heart rate decreases at the same time of the uterine contraction. That is normal. Okay, so early, think of head compressions or that H in CHOP. Then the A in VEAL is accelerations. Always good. So the O means okay, that's fine. Then the last one is L. Late decelerations relate to the P. The P is indicating placental insufficiency. And we talked about the placenta being so important for the baby because it provides gas exchange, respiratory functions, okay, all that stuff, really important to the baby's survival. So if we have placental insufficiency, we really have a big issue, okay? We see late decelerations, which are typically going to be accelerations that are occurring after the uterine contraction, okay? Not good, okay? So the fetal heart rate is going down and it's not good. Whereas in those early decelerations where they're occurring with, the uterine contractions, which is fine because it's a part of the normal labor process, that heart rate goes right back to where it's supposed to be when that contraction is over. Compared to late decelerations, that's not the case, okay? So we know VEAL CHOP. So now we're going to look through more examples with pictures. So we talked about what early deceleration means, right? Heart rate, the fetal heart rate is going to decrease at the same time the uterine contraction due to head compressions. So we don't need interventions because this is normal. We just continue to monitor and document, okay? Normal, a part of the labor process. We expect the baby to pop out soon. Late decelerations, problem. Priority. If they're on Pitocin, or which is also called Oxytocin, stop it. That's your priority. Stop the Pitocin. If they're not on Pitocin, reposition the mom. Those are your prioritized. Like, you need to know them exactly like that. If they're on Oxytocin or Pitocin, stop it. If they're not on Pitocin, priority is repositioning the mom. Then it becomes oxygen, increasing the rate of the IV maintenance, notifying the provider if these don't work, but your priority is either stopping Pitocin. If they're not on Pitocin, reposition the mom. Same thing for variable. We said variable can be an increase or decrease, but here's an example, right? There's no sort of finite pattern. They're just sort of happening whenever these decelerations in the heart rate, okay? Same thing for variable. We said variable relates to the C, which relates to cord compression. If we see this on the fetal monitor, we stop Pitocin. If they're not on Pitocin, reposition the mom. Okay, the interventions become the same, and then oxygen, and then increase the rate of the IV maintenance. If those don't work, notify the provider. Same order occurs, but it's always stop Pitocin if they're on it. If not, reposition the mom. Okay. So, any questions on that? No. Okay. So, fetal heart rate, right? Where there's different categories. So there's reassuring, indeterminate, and non-reassuring. So category 1 is great. What if I'm thinking about, this is a good thing. I'm thinking of accelerations. We already said accelerations are good. Early decelerations are also good with moderate variability, because moderate variability is normal, right? That's that heart rate increasing somewhere between 6 and 25 beats per minute. Those are examples of category 1s, accelerations or early decelerations with moderate variability, because these don't indicate any problems. Indeterminate means category 2, where there's no adequate evidence to classify them, and we need more surveillance, like variable decelerations and minimal variability. Those types of situations where we don't really know what's going on right now, and we need to continue to monitor them, okay? Now, non-reassuring and abnormal are considered category 3. This is really, really bad. This means that we need to have prompt evaluation. We might have to have intrauterine resuscitation and expedite that birth. Okay, example, late decelerations with absent variability, which is basically going to look like this, right? The decelerations are happening after the uterine contraction, and there's no movement or variability in that fetal heart rate, which is indicating to me this baby is not getting adequate perfusion. There is something wrong, okay? So those are the different types of categories. So for category 3, late decelerations with absent variability, what do we say? Priority, stop oxytocin. If they're not on Pitocin, reposition the mom. Then our next priority is administering oxygen. Then we will do a bolus of at least 500 ml of lactated ringers, continue to monitor, get the vitals, maybe a sterile vaginal exam, depending on what's going on. But the last priority is, if none of these are working, notify the provider. But like I said, if they're on Pitocin, stop it. If not on Pitocin, reposition the mom. Any questions about that?
I have a question about the for the category 3, does it has to be absent variability and like decelerations, or could it be one or the other for it to be considered category 3?
Could be one or the other, but typically you see late decelerations with absent variability together. They just happen to usually occur together. You won't really see them like different, but if you see late decelerations, yes, like automatically 100%, you're gonna, automatically like, this is a category 3, but most of the time, and even on your exam, the way I saw it was late decelerations with absent variability, but they could happen differently from each other, right? You could just see a flat line of fetal heart rate, and that would be absent variability, and you could see the late decelerations like we see in this picture. But for the case of category 3, the most commonly presented way is late decelerations with absent variability. Does that answer your question?
Yeah, thank you.
Okay. So yeah, either way, those are all scary situations, okay? So think about that and know your interventions. There's going to be a bunch of priority questions, and I'm telling you what your priorities are. So you're ready, just list them out and you're good to go. So,
I'm sorry, Alicia.
hmm,
Just to confirm, variability has to deal with only the fetal heart rate, and decelerations has to deal with us looking at the heart rate and contractions.
yes. I mean, the decelerations relate specifically to the fetal heart rate, meaning what's going on with that. But they also relate to the contractions, right? Like early deceleration is going with the uterine contraction, whereas late is going before. So there's like a relationship there. But yeah, variability is like heart rate and making sure we see movement, because we said fetal heart rate is not just like this stable thing.
Right.
But when we're talking about decelerations, we're comparing that with the uterine contractions, like what's going on with this baby.
Okay, thank you.
You're welcome. Okay. I know it can be very confusing, but I'm telling you, she's not going to put any other pictures on your exam than the one that you're seeing in your textbook or your slides, the slides, whatever. Those ones, they're going to be the exact same one. So it's not going to trick you, at least in that respect. But she will, like I said, have a question where you're going to have to determine, like, we talked about like accelerations and stuff in the other one, like how to identify it by looking at the chart, like what is their heart rate? Like she's going to ask you that, or what pattern is this based on the image? And you need to know if you saw like where is it, this image right here, that this is an indication of late decelerations with absent variability. So she's going to ask you those things. She's going to give you diagrams, and like I said, they're going to be the exact
whenever you get to that part, but can you just go over, I don't think we got to it yet, but can you just go over like how to count like on like the picture frequency, like the duration and stuff like that, like what like the seconds is, what the minutes is, like to go by? Does that make sense?
Yeah, did we do that?
I don't think we went over it yet. Well, I don't know.
Okay. Let me see. It might have been over here. I don't know if I went over it.
Like, would she put like on the test like a picture and like ask us like what's the frequency of this chart? Like, would she do that?
Yes.
Okay.
She would ask you that. She would probably ask you though, like, what is the like duration? I have to find a picture of that to get an example, because I don't think we specifically did it, but I know that when we're talking about like frequency, we're talking about minutes, and we're talking about duration, we're talking about seconds.
Right, I got that too, but it's just like counting it like on the picture, like I forgot like if the boxes are like 5 seconds or 10 seconds, if that makes sense.
Yeah, I'm trying to see if I can. Okay, I have a picture. So she should have given you a like a practice sheet. She should have provided you with one in like the assignments or something.
Yeah,
Or at
she
least
did.
that's what. Yeah, okay. So there's like different questions like that. So every box is 1 second. It's hard to really see, but I'm going by what I see. And so I'm seeing questions on here that's like, it says the nurse determines that the frequency of the contractions is every like 90 seconds. So wait, I think every box is 10 seconds. My bad. Because I'm like, if I did 90, because I wrote 9, so it's 90. So yeah, every box is 10 seconds. And that's from the start of one to the start of the next. That's when we're talking about frequency, the start of the contraction to the start of the next. And each box is 10 seconds, not 1 second, 10 seconds. But you could count them as one and then just add a 0 at the end when you're done, if that's easier. Right. So the duration, remember, is the start and end of the same contraction, and each box is 10 seconds. So you just have to count how many boxes are there. So if it says duration, you're looking at the same contraction. So how many boxes are in that one contraction? Frequency is how many boxes are in the start of one contraction to the start of the next contraction. So you expect the frequency to be larger than the duration.
Right, okay. And then for intensity, we just like look at the peak of the contraction, and whatever number is closest to that, that's the one that we do.
Intensity?
Yeah, or will she never ask about intensity?
Intensity is more or less either the objective or subjective. So objective is like that palpation. If it feels soft, we're talking about it's a mild intensity. If it's that push in a little bit, then we're talking about moderate. If it feels like a board, then we're talking about strong. And then there's obviously
she's never gonna like
part.
put a picture. Sorry, I'm so sorry, but she's never gonna like put a picture and like ask us like what's the intensity of this contraction. That won't be a question.
God, no, I wouldn't even know what to tell you if
right.
we were looking at that.
Okay, great. Okay, thank you.
Yeah, so like I said, duration, start of the same contraction, start and end of the same one, the same little rump. But the frequency is the start of one to the start of the next. And every box is 10 seconds.
But we give frequency in minutes if she asks us that question.
It could be. So for example, if you have, 90, if you count 9 boxes, that's 90 seconds. You know that's like a minute and a half.
Right.
But
Okay.
I've seen seconds. I guess it just depends on how it's asked. So the practice questions say seconds here, but usually duration is in seconds and usually frequency is in minutes. So just keep that in mind, you know, but just know you're counting the boxes in seconds, not minutes, because that's a big difference.
Right. Okay. Thank you so much.
Okay. You're welcome, because I didn't remember that. I had to check, but yeah, that's how it is. And yeah, I hope that helps. You'll definitely just get like one question with that, one or two. It won't be too many, but they should be give me questions. Those should be the ones you get right, because it's just counting. Um, of course, if the image is clear, because that could be an issue too. Um, but yeah, okay. So we went over that. We went over counting. So okay. So remember, intensity is the palpation of you feeling the stomach, and the subjective feeling, how the mother feels during the labor process in terms of intensity, and what we feel on palpation. Frequency and duration actually have to be counted and stuff if we're talking about that. But okay, so for pain management, remember we have non-pharmacological and then we have pharmacological, right? For this, I'm not going to really get too much into all of it because I did talk about that some in the other video, but just know like there's different things that you could do: breathing exercises, hyperventilation strategies, right? Aromatherapy, music, focal points. Two things that I know she asked for 100%, or actually, let me say three things, is hydrotherapy. The sound of running water can be therapeutic to someone as a non-pharmacologic method during labor, like feeling that pain. Acupressure and sacral pressure are good for back labor. Know that. Know that I don't know how to say that, effleurage, I don't know, I'm probably butchering that word, but it means light touching of the abdomen and circular motions. That is also very good for pain management, as well as frequent position changes. That can also help with pain. I would know those because I remember her asking what is effleurage. I don't know, I'm not saying it right, but she asked about that, and acupressure and sacral pressure, counter pressure, 100%. That back labor, and what the other one is, that it's light touching of the abdomen and circular motions. I would know those. Okay. So I know I ended off here last time. We were talking about analgesics. So, right, we do not want to give analgesics too close to the delivery time. And that's because we're talking about really central nervous system depressing drugs like opioids and stuff, which can be very bad, okay? And the problem is that the timing is so important because they can cross the placenta and cause neonatal respiratory distress. Just keep that in mind, okay? So when the mom gets sleepy, when we're giving them an opioid or an epidural, the baby can get sleepy too. That's why we're trying to understand the importance of, we need to give the medication, you know, not too close to delivery time, because that can cause suppression and things like that. Okay. And we need to monitor the baby. And we can't do that, right, if she's in the middle of the labor process and starting to pass out and that baby's coming down. That could be very scary. So one thing that we can give is nitric oxide, which is basically very safe. It has no effects to the baby. It's not going to do anything. It's effective in 50 seconds after the first effect, and it's pretty good. And it's self-administered. So it's like a laughing gas, nitric oxide. One thing that we could use, but it's mainly used not here, like in Europe and Canada, but it's good. Epidural, we know that's a common thing. We give an injection of a local anesthetic, anything that ends in cane, into the epidural space. Now, we're not putting it into the spinal, like the bones, we're putting it into the space in between the spine, okay? And they're going to commonly complain of a headache. That's one of the most common things that you'll get when you have an epidural. So, what are the advantages? She does ask about this, that it's good. It produces good effects for pain, and the woman can be fully awake during labor and birth. So they could be chilling, standing there fine after they get the epidural. But the disadvantages are that it can cause hypotension within 1 hour of initiation. So if they can have hypotension, that means we monitor blood pressure. It can cause bladder distension. They might not be able to feel anything because remember, it's causing numbness. You're putting something into the spine, which can numb everything below. So Foley catheter, right? It can prolong that second stage of labor. It can cause a maternal fever. So the baby could have sepsis if the mom has a fever. So we need to get a CBC to have a lumbar puncture and a urine culture on the baby because they're at risk for sepsis. Okay, you need to know this, and the adverse effects of epidural, right? So we're talking about hypotension. That's one of the most important things. And if they have like an itching effect, you want to give Benadryl to help prevent with that like high venous feeling that you feel. But remember, every single time I always tell you, unless I've identified certain situations like placenta abruption, which is an example where the mom becomes the priority, but 99% of the time it's always the baby, and it's always monitor fetal heart rate. So here's going to be very simple. Pre-administration priority, monitor fetal heart rate for 20 minutes to see if the baby is stable. Then we want to assess if she's in true labor, because think about it, this is before we give them the epidural. This is when they're about to figure out should this person be admitted for labor. So we need always fetal heart rate, see if she's actually in labor, look at those cervical changes, right? Look at those maternal vitals and do a pain assessment. The bladders need to be empty because remember we said the bladder can become distended, so they may need a Foley, right? The anesthesiologist goes over risk and benefits. They draw a CBC looking for platelets, looking for all of those things. And the priority intervention before administration of an epidural. So before we give it, first we need to do all of these assessments. But before we even try to administer, we need to give an IV bolus of 500 ml of lactated ringers. Think about it. Why? That's going to also help raise the blood pressure to help counteract that potential hypotensiveness that this thing can cause. So before we give it, we're going to give an IV bolus. But the admission, like the assessments are going to be this. Fetal heart rate, see if she's in labor. After we've determined all that, then before we give that epidural, we give an IV bolus of 500 ml of lactated ringers. When we give the medication, priority is fetal heart rate. The second priority is repositioning the mom to a lateral position. Why? If they're laying on their back, that causes, potential compression of that vena cava, causes decreased blood pressure, not good. So first priority, fetal heart rate, then reposition. After we give it 30 minutes after, once again, monitor fetal heart rate. You could always pick that answer when it says, what's the priority? Monitor fetal heart rate, except in the exception of placental abruption. Second priority, reposition the mom. I think you're seeing a trend. Third priority, maternal blood pressure every 15 minutes until she delivers. Doing a pain assessment every 30 minutes to see if the epidural is working, right? Because they shouldn't have any pain. And the fifth priority is monitoring the bladder every 1 to 2 hours because it can't be full. It needs to be empty, okay? Last thing, 30 to 60 minutes after the epidural is given, first priority, right? If they have maternal hypotension, 30 to 60 minutes after that epidural is given, first priority, reposition the mom because we want to alleviate and increase that blood pressure. Then we give an IV bolus. And if the blood pressure doesn't increase after those interventions, we call the anesthesiologist. So these are your general interventions that we talked about here, okay? All of these things. But if they experience maternal hypotension, which I said is a very common side effect after an epidural, which will occur about 30 to 60 minutes after administration, our priority is to reposition the mom and give an IV bolus. Remember, we're not talking about the baby. We're talking about maternal hypotension, right? And that can affect the baby if it gets worse. That's why we need to treat the mom first in this situation if they have maternal hypotension 30 to 60 minutes after the epidural is given. Okay. Like I said, I listed all the priorities here for you. So you can't get the priority question wrong because they're listed here for you. I tried, that's how I found it useful to study for her classes, always identifying priorities because she tends to ask them a lot. I see a hands raised.
Yes, hi Alicia. So pre-administration is basically before administration, right? So even before the pre-administration, we should have them on the bolus, the fluid.
Yes. So
if she asks us a question, okay, sorry, go on.
No, go. It's fine.
So if she asks a question, right, and then she have both, not during pre-administration question about the epidural. Do we choose monitor fetal heart rate for 20 minutes or the IV?
If it says a mom was admitted to the hospital, she thinks she's in labor, and they're preparing to assess the need for an epidural, we're doing the priority assessment is fetal heart rate. If it says they performed an assessment and they're preparing to give an epidural, what should the nurse do before administration? You give an IV bolus at 500 ml. You see, it's tricky, but that's the wording. If it says they did everything, like assessments, they determined she's in active labor and they're going to give an epidural, what should the nurse do before administering? Boom, the fluid. If it doesn't mention that, they said they just came to the hospital, they think they're in labor, they're considering an epidural, right? Priority fetal heart rate. Does that make sense?
Yeah. So one of them is more like telling us like the epidural is about to happen, and then the other one is telling us she just came in and she feels like she's in labor. We have to monitor the fetal heart rate. Okay.
Exactly. So they're assessing the need for all of these things.
Okay.
Yeah. There you
Hopefully
go.
we are able to differentiate and identify what the question is asking.
Hopefully, but I tried to give an example because I could see if it says, I know it definitely will be worded, what should the nurse do before administration? IV bolus. Just IV bolus. Like, you're going to get it right. And yeah, if it says during administration, the nurse is monitoring, after giving an epidural, monitor fetal heart rate. 30 minutes after administration, monitor fetal heart rate. If 30 to 60 minutes pass and they have maternal hypotension, reposition the mom. Okay, so now we're going to go into the stages, right? So we already went through that. So I'm not going to get too crazy in the stages, but stage 1 is effacement and dilation of the cervix to 10 centimeters, right? That's where it ends. So nursing assessment, always priority, fetal heart rate, and then those uterine contractions. Why? We're looking for that variability. We're looking for the decelerations. We need to see that during labor. We talked about why it's important, right? Yeah, we want the maternal history, maternal vitals, but priority fetal heart rate. Okay. Nursing actions, interpret the fetal heart rate and uterine contractions, corrective actions. What do we do if we see late decelerations? What do we do if we see variable? Like, those are the things that's what she means. She's going to ask you things like that. Pain and comfort measures, activity and positioning, shower, walking, birthing bowl, different things to help with pain. IV fluid, strict intake and output. Keep the bladder empty because it delays labor. Remember that. Clear liquids, monitor labs. Yeah, you're going to do all that stuff, okay? But priority assessment, fetal heart rate, okay? That second stage, dilation of the cervix to 10 centimeters all the way until the birth of the child. Once again, monitoring fetal heart rate is that priority. Yeah, we're also going to look at the maternal fatigue and pushing efforts and how much the fetus is ascending, but we need to know that fetal heart rate, right? Because one of the things that happens is they have, the early decelerations, which is normal, but if they have some other sort of decelerations during this, not normal. Nursing actions, they are pushing the baby. So now it's not about as much about, positioning, things like that, because they're already in this labor process. So we need to have coaching. We need to make sure that when we position them in this situation, it's helping them push the baby out, right? We're looking for fetal descent, right? We can't have the mom moving around all over the place to try to see what's going on with the baby and see if the head is coming towards the vagina, okay? We're preparing for delivery, right? We have perineal hygiene, right? Because they might poop while they give birth. That's totally normal. And checking the bladder, because remember, it should be empty while pushing, right? So think about this. And sometimes it's not about like memorizing what you need to do, but it's like, what am I going to do while they're giving birth, right? Help them with, breathing efforts and making sure, they're comfortable as they're pushing and looking at the baby and looking at the heart rate and, making sure that, the bladder and the perineum, they're all being cleaned or the bladder's emptied. For stage 3, we're talking about birth of the baby until the delivery of the placenta. Okay, so the priority now in this becomes the APGAR scores, because that's going to tell us a lot. So APGAR scores has appearance, pulse, grimace, activity, and respirations. That's what each letter stands for. And you score at 1 minute. So 1 minute when they're born, and then again at 5 minutes. And it assesses these parameters. It assesses heart rate, if it's absent, slow, or fast. Respiratory rate, absent, weak cry, or a good strong yell. Muscle tone, is it limp or lively and active? Response to irritation stimuli. Color, right? Evaluate the cardiorespiratory adaptation after birth. So we're looking at all of these things. As well as we're looking for placental separation, right? After we do the APGAR score, we're looking for that because the the placenta is supposed to come out. Once that placenta comes out, we must give Pitocin because that's going to prevent postpartum hemorrhage, okay? So just keep that in mind. And we're looking at the status of the uterus after delivery, and we're assessing for perineal trauma. So during this phase, right, baby's born. So we want skin to skin with the mom. We want bonding. We want perineal care because they might have pooped and they might have had all these other problems, right? And comfort. Okay. So I think I don't know did she get into the APGAR scores with you or no? I don't think she did because if I'm looking through my notes, it will be after. Okay. Well, did she put that on your outline?
She didn't.
No, she didn't? Okay. That's fine. But I want you to keep in mind what the APGAR score is, and that when you're in stage 3, the priority is to obtain the APGAR score at 1 minute and at 5 minutes. And these are the sorts of things that it's assessing for: heart rate, respiratory rate, muscle tone, responses, irritant stimulants, and color. For example, well, like I said, I'm not going to get into this now, but when you do the APGAR score, there's certain colorings that are going to be abnormal and normal to see when they're first born. So that's why coloring is important. Okay. And you also said the last chapter is 21, right, for your exam?
Yes.
Yes. Yeah.
Okay. So we already had a long discussion on all of these different positionings for the baby in that last video. So like the occiput posterior position, right, where the baby's back is to the mom's back. If you were able to see inside her stomach, the baby would be basically facing you, right? So the maternal risks are if this baby is in this position. Now, occiput means, remember, the head. We're talking about the head being down, okay? So it can cause prolonged labor, and it can cause basically perineal laceration. In other words, the rectum can start to tear as a result, okay? And that could be quite painful on its own while she's giving birth. So how do we know that the baby is in this position? Well, if the mom has intense back pain, a prolonged active phase, which is one of those phases in the first stage of labor, and arrest of dilation or arrest of descent, that's how we know that the baby's in this position. Now, nursing care is that we're going to have to prepare for a longer labor, right? Changing positions, moving them side to side actually might get the baby to turn around. A knee to chest position where the hands, where it's going to help with the baby to come out in this anterior position. We could also perform, remember, sacral counter pressure, where your partner applies firm pressure to the sacrum to decrease pain. Okay, so we're going to prepare for longer labor. We're going to help change the position, moving her side to side. Hopefully that'll get the baby to turn around. Knee to chest position. Hopefully the baby will turn around. And sacral counter pressure to help with the pain. Support and encouragement. Anticipate an operative delivery like an episiotomy and a vacuum. Okay. And remember, episiotomy means we're cutting into the rectum. Maybe even a C-section, depending on what's going on, okay? Because this is not the normal way for the baby to come out. We want them to come out opposite occiput, anterior position. That's how we want them to come out. So if they're in this position, we're trying to do everything we can to get the baby to turn around before we go into these like deeper options, okay? Another issue that we could have is shoulder dystocia, which is basically an OB emergency. It's because it's a difficult or delayed delivery of the shoulder after the birth of the head. So remember we were talking about when the baby's moving, one shoulder comes out in the internal and then the external rotation, the other shoulder comes out. Well, something goes wrong here, okay? And basically the shoulder is like stuck above the pubis symphysis, and the baby can't feel that external rotation, okay? So they can't get that other shoulder out to come out. This is a problem. Now, usually we'll see this in macrosomia or really big babies, prolonged second stage, Also turtle sign, where we see the baby's head come out and then disappear. That could be hints that this mother is having shoulder dystocia. I would know turtle sign for sure. Maternal complications, right? This can cause postpartum hemorrhage and cause an operative delivery, okay? Now, complications of this position, because the shoulder stuff can cause hypoxia, fractured clavicles, right? Because the pressure of mom's trying to push this baby out and it's getting resistance because the shoulder is stuck, and nerve injury. So we have helper, which is the steps in which you perform for someone who has shoulder dystocia. So if the mom's going through this OB emergency, first thing is call for help and hit the emergency button. That's what the nurse can do. The E is evaluate for an episiotomy. That's what the OB does, not what the nurse does. What the nurse can do is the L, legs. They do something called McRoberts maneuver, whereas two nurses stand on either side of the mother and bring the knees back to the ears and open the legs to change the diameter of the pubic bone. So they're pulling the knees all the way back to the ears with the legs open, which can help change the diameter of the pubic bone and maybe help remove that shoulder, okay? The nurse can do the P, or suprapubic pressure, where the legs are still in McRoberts maneuver, but the nurse pushes in and down on that pubic bone to try to push that shoulder out, okay? Then E, or enter rotational movement, that's done, maneuvers that's done by the OB. The OB can remove the posterior arm, but the nurse and the OB will roll the patient onto her hands and knees to help get, this baby out. So you need to know the steps like this, but also know which ones the nurse do and which ones the nurse can assist in, because that's what we're looking for. That's what she's looking for to see out of all of these steps. What can the nurse do? So the nurse can call for help. The nurse can put them in McRoberts maneuver. The nurse can put that suprapubic pressure, and the nurse can help roll the patient on her hands and knees. So then we have preterm labor, right? Where we have this onset of regular contractions and the uterus having cervical changes before 37 weeks gestation. So manifestations include pelvic or lower abdominal pressure. They feel really heavy, menstrual-like cramps, change and increase or in vaginal discharge, low dull back aches, vaginal spotting, and uterine tightening and contractions. If we see any of this, we know they're in preterm labor. And the key indicator that's going to let you know this is that they're having regular contractions and seeing these things like the low back pain, the contractions before 37 weeks gestation. So management, activity restriction, okay? It's not really that effective in this situation, okay? It's not going to really help. The priority for this, based on evidence-based practice, is hydration. Our priority intervention for preterm labor is hydration. 8 to 10 glasses of water a day to prevent the cramping and dehydration. The isotonic solutions is that first line of treatment for a woman in preterm labor. So when you're thinking about preterm labor, our priority is hydration. We also want to identify and treat infections. So UTIs can cause preterm labor, know that. Tocolytics can delay labor, so we might give them one of these, especially if it's preterm labor before that 37 weeks. And corticosteroids before 34 weeks gestation. So basically, with this is that we need to give corticosteroids at least 24 hours after administration to be effective for fetal lung maturity. Okay, so if this mom is at risk, for preterm labor and even to help prevent preterm labor, we give corticosteroids before 34 weeks gestation. And it must be administered 24 hours before delivery. So it's administered before 34 weeks, and it must be administered 24 hours before delivery, and that's going to help with the lungs, okay? And the drug is beclomethasone, okay? So those are some ways that we could help with preterm labor, but that priority intervention is hydration and typically IV fluids of isotonic solutions. We said tocolytics, they can help delay delivery for up to 48 hours because they can decrease the frequency, duration, and intensity. And when we were talking about drugs, I mentioned in one of my videos, if you ever watched them, is the terbutaline, which is one of those beta adrenergic drugs, which essentially is not only works on those beta receptors, right? Helps with asthma because it's a beta 2, but it also delays preterm labor. That's why I did mention that a long time ago, even though it might have seemed like, hey, why did we do that then? Well, now we know why it was mentioned. So, side effects, we're talking about symptoms are related to beta stimulation. So, beta 1, beta 2s. So, we're talking about, potential tachycardia, right? Potential hyperglycemia, anxious flush, things like that. I see a hand raised.
Yes, I'm sorry. I just wanted to confirm the corticosteroid that we give for fetal lung maturity is the betamethasone.
Yes.
Okay. Thank you.
You're welcome. So, yeah, tocolytics, like I said, they're one of the managements that we could use to help delay preterm labor up to 48 hours. So not beta blockers, beta adrenergic drugs like terbutaline, calcium channel blockers like nifedipine, non-steroidal anti-inflammatory drugs like indomethacin, and magnesium sulfate. Okay. And that's because it's used for fetal neural protection. So it helps protect the neurological status of the baby by decreasing that incidence of cerebral palsy. That's one of the reasons why we give it as well. But one of the common ones is terbutaline, and you want to know these side effects: potential hypokalemia, hypotension, hyperglycemia, flushing, and anxious feeling. Okay, but these are all the drugs that you can use, and she will ask you probably a select let apply and pick which are examples of tocolytic drugs, and these are your drugs right here. Okay, always priority, fetal heart rate, then contraction pattern, then dehydration, because we said our priority intervention for someone who has preterm labor is hydration, right? Also range of movement and infections. But priority is fetal heart rate, because remember, what do we say? UTIs can cause preterm labor. Management, positioning, assess the cervical status, right? With a sterile vaginal exam, IV fluid bolus, obtaining cultures, administering tocolytics, steroids, vital signs, strict INOs, labs. All of these things are the things that we could do for nursing management, okay? But like I said, priority assessment, fetal heart rate, and then contraction, and priority intervention for someone who's at preterm labor, hydration. Do not forget that. Okay. So another thing that we have is induction, which is the deliberate stimulation of those uterine contractions before the onset of spontaneous labor. In other words, we're making the mom give birth before. Okay, we're actually causing it to happen. That's what induction means, okay? So why would we do this? Well, let's just say the mom is past 40 weeks gestation and they're still pregnant. We want to do induction. If they have dystocia, right, or we're talking about that difficult labor, or we're having the problem with the shoulder and everything like that, we're going to do induction. If they have prolonged rupture of membranes, remember, the membranes need to rupture within that certain period of time. I think it was within 12 hours. I don't remember. You can correct me if I'm wrong, but there was a certain amount of time frame in which the membranes need to rupture if they're in labor, and if not, they're at risk for infection. So if it goes past that point, we give induction. Like I said, I don't remember the exact hours, so definitely go back to find that. Intrauterine growth restriction, another reason for induction. Preeclampsia, diabetes, Rh isoimmunization, fetal demise, chorioamnionitis. If they have that, all of those are reasons why we would give an induction. Now, know these absolute contraindications. Complete placenta previa, we're not going to induce them. Placental abruption, we are not going to induce them. If the fetal is transverse, we're not going to induce them. If they have a prolapsed umbilical cord, it means it's around them, we're not going to induce them, right? Like that, where that cord's like around the neck of the baby. Okay, what else? If they have vaginal bleeding with an unknown cause, do not give induction. If they have active genital herpes infection, do not induct or induce them. Why? Because if we induce them to labor, we can give the herpes infection to the fetus, and that could be deadly, right? Abnormal fetal heart rate patterns do not induce labor, okay? So, how should we figure out what to do? How should we determine induction? Well, the first thing we're going to do is we're going to look at a Bishop score, and it's an assessment of the woman's cervix done through a sterile vaginal exam. This tells us the pre-labor surgical changes that would favor dilation, and this is going to help us know if we should induct them, because it's going to tell us the probability of success by using this Bishop score. So a score of 6 or less indicates a cervical ripening method should be used over induction, and we'll talk about cervical ripening. Whereas a score of 7 to 10 means use Pitocin, which is going to stimulate contractions, and it's going to help the baby come out. Okay, so no, a score of 7 to 10, use Pitocin. That means we're going to do induction. If it's a score of 6 or less, we're not going to induce them, but we'll do cervical ripening. And cervical ripening is like a little different. So essentially, we're going to give different medications to help induce them. We're not going to stimulate contractions, but we're going to sort of like open the cervix. And there's different ways that we could do that. So we have preparations including prostaglandin E2. So we have dinoprostone, Cervidil, and Prepidil gel, misoprostol. But the problem is, we've talked about misoprostol before. The problem with this medication is that it could also cause abortions, okay? It's also called Cytotec. Prostaglandins you cannot use with asthmatic patients because prostaglandins can cause inflammation of airways, not good. You have to wait 6 to 12 hours after administration to check if their cervical change occurred, okay? The score of that Bishop score should go to a 7 or higher. So what's going to happen is we're going to give them a cervical ripening agent if that score is less than 6, if that Bishop score is less than 6. We're going to give one of these medications, okay? If the score goes up to 7, then we can go and we can give them like the Pitocin and stuff. If not, then we're still going to try with the cervical ripening agents, okay? Now, a major adverse effects of these medications is that they can cause uterine hyperstimulation and fetal distress. So, something that I want to point out with these is when the priority when giving a cervical ripening agent is that you must always can do continuous fetal heart rate and uterine contraction monitoring because they can go into labor. So when we give a cervical ripening agent, right, it's a score of less than 6. We give one of them, we wait 6 to 12 hours. If their cervical changes occurred, the score should go to 6 or 7. I mean, higher than 7 or higher. If it goes to 7 or higher after giving the cervical ripening agent, then we can give them Pitocin and induce them. Okay, that's pretty much how it works. Yeah, I see a question.
So you're saying that when it's below 6, we don't want them below 6, but when they are not able to go above 6, we give them the cervical ripening. But if they are able to go above 6, then you give them just Pitocin.
Exactly. So that's pretty much what happens because the cervical ripening is just going to help, open like the cervix and cause cervical changes, but we need the contractions too. So when it gets back up to the normal point of the Bishop score between 7 and 10, then we'll do that. But remember, we're only doing this if they have any of these indications, post-dates, prolonged rupture membranes, things like that. That's the only reason why we would use inductions or cervical ripening agents. There's no other reason why we would use these. Okay. Also, go into your drug guide, go to your this chart where you have it in the textbook that just sorts of goes over the nursing implications for each of these medications. Definitely do look these over. Okay? Just look over the chart, just read it through. Okay. So then we have also an amniotomy. Oh, I see 2 hands raised now. or one hand raised. Is there any questions?
Yeah, I was wondering, when do you reassess? Is it after the 6 hours or the 12 when you give the for the cervical ripening? To see if the
Anytime
bishop
between
score.
6 and 12.
Okay.
Anytime between 6 and 12. So after you give it, wait 6 to 12 hours, somewhere between that time, check for cervical changes. If it's occurred, and then the score should go up to 7 or higher, then we'll give them Pitocin. Okay, any other questions? Okay, so then we have an amniotomy, which is also going to help induce labor, which is basically where we have an artificial rupture of membranes. Remember, we said that we can't have the membranes, right, be delayed from rupturing for too long because that increases the risk of infection. So a baby must be delivered within 24 hours of a ruptured membrane, right? But if the membrane isn't rupturing and we see clear cervical changes, we're going to need something to do that. So we will induce labor and we will actually artificially rupture the membranes, okay? So what we need to do is we need to monitor the fetal station before the rupture. Before the artificial rupture occurs, we need to know their fetal station. We need to know if they're at fetal engagement, okay? We just need to know that because we need to know where that baby is in terms of coming down the pelvis, right? Coming down that area to know, okay, if we rupture, this baby's going to be coming down, okay? It's not going to be staying up. It's not going to be floating. Then after we rupture the membrane, the priority is fetal heart rate and maternal temperature every 2 hours, okay? So fetal heart rate and monitoring maternal temperature every 2 hours. And that's because there's also a risk for infection. So those are your priorities here, okay? Now we have oxytocin, right? We already talked about this. We give this 6 to 12 hours after the administration of a prostaglandin. We talked about the cervical ripening agent, dinoprostone, right? We said if after that, when that bishop score is less than 6, we give a cervical ripening agent. Then when that score goes to 7, we'll give them Pitocin, right? So we have to give it after 6 to 12 hours, typically after the administration of a prostaglandin. It is diluted in ice. When I say it, oxytocin is diluted in the isotonic solution and administered as a secondary infusion. Know that. The primary line, which is that isotonic, right? So we have the Pitocin is going to be the secondary, and the isotonic is going to be the primary, okay? So, you know, oxytocin's on the top, and then the primary is hanging on that, like, little hook. We insert into the primary line at the most proximal port. I want you to know that, the most proximal port, okay? So, which basically just means the closest port. So, priority assessment always is a monitor fetal and maternal response, which is looking at fetal heart rate and fetal and the uterine contractions. So I remember for her, when she had the exam, she did ask how much you give, like, the oxytocin, and it's basically this, where you have to begin at 0.1 to, I mean, sorry, not 0.1, 0.5 to 1 MU per minute, and increase the dose every 1 to 2 MU per minute every 30 to 60 minutes to achieve 3 uterine contractions in 10 minutes and at least 45 seconds to 60 seconds in duration. So we basically give the oxytocin so that we can have 3 uterine contractions in 10 minutes that last at least 45 to 60 seconds in duration, okay? So when we give oxytocin, our priority is always fetal heart rate, uterine contractions, monitor for pain, then we monitor for fluid status, and then we need to know when to stop Pitocin. And I'm going to show you where we stop Pitocin. And remember, we give this as a secondary infusion. So when would we stop Pitocin, right? We seem like it sounds like a pretty good drug, right? It's helping with contractions, it's helping get the baby out. Well, the problem is that with Pitocin, we could have something called uterine tachysystole hyperstimulation. So we said the goal was to have 3 uterine contractions, right, in 10 minutes that last at least 45 to 60 seconds in duration. When we have uterine tachysystole, we have 5 or more uterine contractions in 10 minutes. And they're going to last 2 minutes or longer. You see the difference, right? So regularly, Pitocin, we want to get 3 uterine contractions in 10 minutes, at least 45 to 60 seconds in duration. That's why we begin at 0.5 to 1 as the doses and increase the dose by 1 to 2 every minute for 30 to 60 minutes until we get 3 uterine contractions in 10 minutes that last 45 to 60 seconds duration. The problem is that we can get this uterine tachysystole hyperstimulation from Pitocin, which is causing 5 or more uterine contractions in 10 minutes, and it's causing them to last 2 minutes or more in duration. And they occur within 1 minute of each other. You see how frequently these are occurring in this chart? And we're also going to notice late decelerations followed with minimal and absent variability. So we could see that sort of minimal variability here and leading to absent variability with late decelerations. So if we see this, we see all of this stuff, our priority is to stop Pitocin. We see the 5 or more contractions in 10 minutes, lasting in 2 or more minutes in duration, 1 minute apart, late decelerations, minimal and absent variability, we have to stop. Any of those signs letting us know we really need to stop. Any questions about that? Okay. So the next thing is a prolapse umbilical cord, which basically is when the umbilical cord lies below the presenting part of the fetus, which is basically when the baby's in that floating range, that higher station. So it's really, really not good. I think let me show you like a picture. That way it like makes more sense. Okay. So this is just for you all to see, but this is an example of what umbilical prolapse would look like. It could also lead to potentially the umbilical cord going around the baby's neck, okay? So that's the problem with the prolapse umbilical cord. And the risk is when they're in the floating station. Know that, because we said the negatives are floating, right? So what we'll typically see is a steady drop in the fetal heart rate on the monitor. If we see a steady drop in the fetal heart rate, our nursing accident, we know they have a prolapsed umbilical cord, our priority is stop Pitocin, okay? We're going to hit the emergency button, then we're going to do a sterile vaginal exam, push, this is what you need to do, you need to push the presenting part of the cord up, but you cannot take your fingers out, so you're keeping your fingers in there, and you're pushing the presenting part of the cord up, okay? And the mother needs to be put on in a position where her head is on the bed and her butt is in the air. And then we give oxygen and an IV bolus, okay? But even when you turn them and put them in this position, you cannot move the finger. So you're going to stop Pitocin. You're going to do a sterile vaginal exam. You're going to push that presenting part of the cord up, but you can't take your fingers out even when you're moving them, okay? Until we can get them to get the delivery of a C-section, but the fingers have to stay there, okay? So, we have operative vaginal deliveries, which is basically when there's traction to the fetal head during birth through like forceps or vacuum, which is kind of like a plunger to the head to add to aid in that maternal expulsive efforts, right, to help the baby come out. So, one would we typically use if to shorten the second stage for the well-being of either the mother or the baby, or rotation of the fetus, the baby's moving, right? Maternal risk, though, is that it's for the mom, it's going to cause them to have an episiotomy, like a laceration of the perineum. For the fetal, know this, the vacuum can cause cephalohematoma, which is a bruised head, which increases the risk of jaundice. For forceps, it can cause abrasions, lacerations, and facial nerve injury, causing permanent facial paralysis. You need to know those. You need to know that if they have an operative vaginal delivery for the baby, the vacuum will cause a cephalohematoma, which is a bruised head and increased risk of jaundice, and the forceps will cause abrasions, lacerations, facial nerve injury, permanent facial paralysis. Okay, let's see how much is left. Okay, not much. So the last thing is a cesarean delivery. So when are we going to do this? Well, labor arrest, right? The mom is pushing, nothing's happening. The labor process stops. We're going to have a C-section. Non-reassuring fetal tracing, late decelerations indicate C-section. Know that. Malpresentation. We were talking about breech and transverse, right? Those aren't normal positions for the baby to come out. C-section. Macrosomia, big baby, C-section. Previous cesarean delivery increases your risk for having a C-section again in the future. Complete placenta previa. Remember, we don't induce in placenta previa, placental abruption. We don't induce. They have to have C-sections. Okay. Active genital herpes. We said they were contraindicated in inductions, but we have C-sections for them. Umbilical cord prolapses. They must have a C-section. Okay. Know that. Know when we do it. It's going to be like a selective that apply. And the ones I highlighted are the ones that she focused on the most. Priority preoperative, assess fetal heart rate, as well as checking NPO status. Remember, surgery, they're not supposed to be drinking or eating. Baselines, vital signs. So we need to look at the vital signs. We need to look at the chart and the lab data. We need to also look at IVs, making sure that we have an IV there, that we start an IV, and that we administer fluid of 500 ml of lactated ringers, emotional support and all that. But the priority always preoperatively before the C-section is fetal heart rate. I see a hands raised.
Yeah. I don't think we have to do cesarean delivery. I don't think we got a chance to go over that in class yet.
Oh, okay. Well, then just know, since we talked about induction, right? And the reason why we don't, those like contraindicated reasons for not inducing the mom is because these are those complications are going to have a C-section. Yeah, I might have went over. Okay. And yeah, so I'll just leave it there. But just know that when you do have a C-section, that the baby needs to be delivered within 30 minutes. And then after that C-section, your priority becomes looking like at the fundus and lochia, because you're looking at post-operative bleeding, because postpartum hemorrhage is very problematic after a C-section delivery.